like to be there with you in person in Phuket, Thailand, but unfortunately during the current situation we are not able to travel, so I hope we will see us next year somewhere. But today I would like to give you an update on 3D brachytherapy from history to 2020, and you will see in my slides first some historical background, and I'm sure you are all aware of this and you have seen this before, but I would like to give a short historical background. So this image is still one of my most important images because it shows what happened, and this is now 20 years ago in November 1999, where we already had an MRI available, and we saw on this MRI a huge tumor at time of diagnosis and also at time of brachytherapy after external beam, still a very, very big infiltration into the parametrium. At this time, we tried to irradiate this, we tried to cover it, but we could just cover this central part here with intracavitary. No needles have been applied. This part of the CTV was completely uncovered, which resulted finally in a recurrence 9 months after treatment. Patients died. This is for me such an important issue because it shows that we had MRI, but the MRI only did not change the practice. Only when we started to contour appropriately and when we also changed the irradiation technique. Sometimes this reminds me now with the MRI LINAC. Everyone thinks the MRI LINAC will be actually the solution for everything. However, using MRI only is not enough. We also have to change our technique, and we also need clear concepts. Changing this technique was also changing our practice of prescription. In former time to 0.8, then this part of the tumor was not covered. By using a needle in here, we could also cover this part. So this was this big change, also using those volume histograms to describe those to the target. This diagram comes from my colleague Li Titan from Cambridge University. She is teaching at the Segestro teaching courses, and this is a survey which shows the amount of participants who are using X-rays and who are using CT and MRI. And you see here that around 12 years ago, 70 to 80% were still using CT, but also 60 to 50% were using X-rays in brachytherapy only. And this changed, and you can see now that almost only 10% are nowadays using X-rays, and the majority is using CT and MRI, and this is from the ESTRO teaching course, so with participants from all over the world. The same is here for those prescription. Point A was almost 80-90%, the main parameter. Now it's dropped to only 30%, while the other 70% are using now TVH-based prescription. There's a clear trend all over the world, and I think we can call it already state-of-the-art what is done now with MRI and with CT and volume-based prescription. It was also important to change the way of implantation. These have been prototypes in the early phase. We are still using these in Vienna and on some occasions. What you can see here is this striking effect that with intracavitary only you are not able to treat infiltrating tumors, larger tumors, complex tumors, but with needles you can really have a very conformal irradiation technique. The commercial applicators have become available. For instance, the Venezia applicator. I'm also aware of the Geneva applicator. Also the other company, Varian, is providing something. And with these applicators, you're able, what you can see here, to optimize to fine-tune the dose distribution. What is quite important in the history of planning, we are not using point A anymore. Like before with standard loadings, we have to optimize, we have to change dwell positions, we have to shift dwell positions so that we can avoid overdosage of organs at risk, for instance, by optimizing optimizing it. The needles, and this is quite important, and I'm saying this now since 10, 15 years already, we have to be careful that we are using the needles not too extensively, because on the parametrial parts, left and right, we have different organs at risk which are not contoured, the urethra, the nerves, vessels. So what you can see here is that we are optimizing intracavitary parts, but the needles are only this very low dwell times. With inverse planning, there was a lot of discussion about this. The problem was when we used inverse planning in the early phase. You can see here standard loading with a very, very high hot spot in the center next to the GTV, also next to the intrauterine channel where the malignant cells are. Then we tried with inverse planning, and suddenly we also got cold spots. But you just look at the D90 at 2, 3, 4, 5 organ doses. It's not sufficient. You always have to check the underlying dose distribution to make this possible. Because with inverse planning, what we are not really taking into account is what is not contoured, parametrial tissues, the vagina, the nerves, the vessels, the urethra. And this shows, for instance, the manual plan, hotspots in the parametrium, very, very small, and with inverse planning we have this huge hotspot. We have not clear evidence what this means, but in most European centers we are trying very much to avoid these hotspots outside of the uterus in the parametrial tissue. The needles are just fine-tuning, so most of the dose, blue 100%, 200% isodose, is limited. Even if we add 1, 2, 3 needles, it is only a very, very small increase in this hotspot volume, just 36%, 36 cubic centimeters, for instance, with this double isodose. That's quite important. It also shows that we are using with manual loading most dwell time is in the ring and the tendon, and the needles again are just fine-tuned. What is at the moment, and now I'm already in 2020, what do I think will be the future? I think inverse planning only will not be sufficient. We need automatic planning. We need dose volume constraints for that. We also need point dose constraints. We need dose gradient constraints, dwell-time gradient restrictions, and then inverse planning might work where intracavitary and interstitial is analyzed and optimized separately. We also need constraints for the dwell-time distribution to avoid hotspots. And you also have to take into account the XP2 for the total dose and also risk effect-based plan ranking. So I think this automated planning in brachytherapy will be a future, but we have to work that it becomes realistic. What do I mean? These dose gradients, I mean that in intracavitary and also in combined intracavitary interstitial, we have a dose gradient which is always showing to the left and to the right. So it means we have always the central part where the GTV is, where the intrauterine channel with the malignant cells originated. This should be our hotspot area, and then the dose should be painted, but it should become less and less and less as we go to the left and to the right. And this makes brachytherapy so effective that we don't have this homogeneous dose, but that we have a very inhomogeneous dose. And we have to keep this dose gradient, and automatic planning has to help us that this is kept. We also, in daily clinical practice, have looked mainly at D90. So the dose volume histogram of D90, this is this isodose which covers 90% of our red CTV, but this is not sufficient. We also should take into account that what is the minimum dose out here, and this minimum dose is the D98. So we also look at the D98 that we avoid really underdosage. And what we can see here also that these hotspots, for instance, we are now in the D50. So an inverse automated planning, if we really want to control all of this, we have to really automatically integrate the entire VH, and not only the Q90 for the future. Also the IRCTV is of importance, which is actually related to this isotope. What you can see here is an image of a case a couple of weeks ago, where we have very strange looking tumor with the GTV located on the posterior part here, very eccentric, because here is the intracavitary channel, but the GTV is actually on the posterior part between the rectum and this channel here. So we were using needles, as you can see it here, and these needles are there to cover the GTV, but also to boost the GTV. So what we are doing here is actually the brachytherapy is already a boost, and the GTV we give more dose, so it's a boost in boost technique, what we are doing here actually. So we have on the one hand the orange isodose to cover the CTV, but we have this yellow hotspot for the GTV. And I think this becomes more and more complex, and automatic planning might help in the future. This is the same patient, but at different image level. Also seen here. Maybe we need additional constraints. So what is if we have a high hotspot here close to the bowel? We can, of course, load the 12 times here, but what is happening if the needle goes up and down a little bit? So it's robustness of plan. Maybe you know this from external beam, of course. And maybe we also have to make plans which are more robust. It means that we might have additional constraints not to use too much dwell time in locations which could potentially come closer to an organ at risk. It is always has been always a question: what is happening if the needle goes into the vagina, into the vaginal mucosa? Do we allow well positions here or not? Inverse optimizer doesn't know where the vagina is, so we have to tell it. So we have to again think about additional constraints for automated planning. From the ISTRU, we have this concept, the concept of the bladder, rectum, sigmoid, bowel dose, but also from spatial dose distribution. So we have the 2 points still available. We have this situation here, the ICU bladder point. In this situation, the ICU bladder point gets actually a different dose here compared to here. Why? In this situation, it gets a high dose because the bladder neck gets a high dose. This might be more problematic for urinary function compared to the left side, where the hotspot is more in the upper part of the bladder. So the ICU bladder point does show us if the dose is at the top of the bladder or if it's at the bladder neck. We also have this vaginal point in the mid and lower vagina, this tip point, and there's evidence coming up for vaginal morbidity. These were the tips points which are correlated now with the situation in the lower, mid, and upper vagina, and we are able to analyze this vaginal morbidity. I would like to refer to this paper which we did together with Kajian from Denmark. It is more or less summarizing the current evidence, and we have here different dose effect curves. We have dose effect curves for local control from retro-embrace, which is shown here, and I can tell you that just at the moment we are providing in preparing these dose effect curves for embrace 1. This embrace 1 data is just analyzed, it was submitted to it, and then we also are able to produce local control data for embrace. This is from retro-embrace here. But for already preliminary and also some mature embrace data, we have rectal morbidity. So you can see here T2CC versus rectal G2, 3, and 4 morbidity with a clear trend of higher doses producing more side effects. We also have here the recto-vaginal point correlated with vaginal stenosis, also a dose effect curve. Here, 2 dose effect curve because it also depends on the external routine prescription, of course. Same for diarrhea, 2 dose effect curves for 2 different values. So we have the 45 gray external beam, and this is the 50 gray external beam. So if you give 50 gray external beam plus brachy, you already have a higher chance of diarrhea in these cases here. And if you have now the bowel D2CC as an additional parameter, you see with increasing bowel dose also have an increase in diarrhea. And now I could go on with cystitis for the bladder and also for the ICU bladder point with urinary incontinence. So you can see here cystitis, it is more related to the whole bladder, to the T2CC, to the whole volume, and urinary incontinence is related more to the ICU bladder point. Why? Because the ICU bladder point actually gives the dose here at the bladder neck, which is more related to this incontinence. So what is important that we are not looking just bladder grade effect, but we have to really distinguish between cystitis and urinary incontinence and the other endpoint. But that is quite important because in the past we just had bladder morbidity, rectum morbidity. But it's a different. Same with the bowel. Diarrhea is more from the volume, while, for instance, the fistula is more generated from a hotspot. So different parameters for different morbidity endpoints. Those who are in EMBRACE 2, and at the moment we have one active center from Southeast Asia, it's Tulanokson, which is participating in EMBRACE 2, but also Sirirai Hospital has joined EMBRACE 2 recently, and these 2 hospitals probably know very well our planning aims that we have for EMBRACE 2. A lot of planning aims, and you see how complicated this became now. So I think for the future we really need automated planning, because otherwise it is very, very difficult to always look at all these different points here and DVH curves. So this is the situation we have. But we have to be careful. We have to be very careful. And this is, again, from the same reference as before, because there is different evidence. So for rectum and bladder, we really would like to have this hard constraint. They are very, very important. Also for the sigmoid, there is a constraint, but this is not so clear. So you see here, there's an increasing priority. And the same, of course, is sometimes people that say, I have 6 different parameters. How can I achieve all of them? Still, it's important to be then comes less. Also, the overall treatment time would be also a constraint. So, as a hard constraint, 55 days, and as a soft constraint, it would be an ideal situation. I know that in many centers of the world it's not possible. To each other to have. And you can see this in the same reference. Maybe in the future we can have a risk effect-based dose prescription for each individual patient, so that you say what is the probability of the recurrence, is it high or low, and what does the outcome mean. For instance, if you have a dose less than 85 grade, it is a high probability of a local failure. And the outcome of a local failure is, of course, substantial. It results in most cases with death of the patient. So this is very, very high priority. On the other hand, we could think about what does it mean if we have a shortening of the vagina. Yes, if the pips it's above a certain value, quite probably, but maybe for this individual patient, shortening of the vagina is not that important as compared to the outcome of the local failure, and this could be ranked lower. So for each patient, maybe we can make this risk and effect those prescriptions with a point system or something like this. Nothing has been published on that, nothing is fixed on that. This is just an idea of where we could all together come the next step. What will help us for this, and those centers who are in in Embrace 2, and you have a certain amount of patients, then you get access to this monitoring tool. We think that this monitoring tool can maybe also help a little bit more, maybe also for in a registry trial. What can you see on this monitoring tool? You can see the mean value of all centers on the one hand, and you can see your mean value. You can see, for instance, what is your probability, and let's look at the rectal here. So all centers fit in about 80% the soft constraint, in 70% the hard constraint, and only in 1% of cases in Embrace 2, the hard constraint was exceeded. And this is one center you see here too. So it's one center now. It's I will not say which center, but it's a center in Embrace 2. And this center only had 2 cases where they fulfilled the constraint, but 4 cases were above the prescription. So maybe if all the different centers get a tool like this, they can compare, and they can even have some kind of competition, because everyone, of course, would like to be better than the average, and would like to have this enough value. We are talking a lot about MRI, but we should not forget, and this is maybe at the end of my talk, what is also coming up, maybe after 2020, is that ultrasound is quite good tool for those who have only CT, because it has been shown that with ultrasound you can track your applicator, you can really see your target, which you can't see on CT, but you would be able to contour an ultrasound and then to copy this target volume on your CT, and then with CT you can finally do a quite good plan here. So at the end, I think new concepts and techniques coming up. Implantation guidance with ultrasound is quite important, because many centers have problems to needle constraints for gradient and cell positions, risk effect-based planning guidance, and because this becomes more and more complex, too many points, too many EVH constraints, too many contours, we also have to think that even also in brachytherapy, automatic planning to assist the physician, the physicist, is a future, and I think this is my priority, to work on automatic planning aspects for cervical cancer. And not only cervical cancer, but automatic planning is already taking place for HDR, prostate brachytherapy, and I think it will be also done for gynecological, for head and neck, for anorectal, and for all the other different clinical types of them. Thank you very much for your attention. I'm so sad that I can't be with you in Phuket. If I look out of my window, I can see snow falling. So it has in Vienna -5 degrees Celsius and snowing. So I hope that next time yes, either in Thailand or I could welcome you here in Vienna. Thank you very much. Maybe we have the chance to discuss this. Thank you very much. I can hear you.
Yes, okay. From my question, I want to ask about the last slide, the combination of ultrasound and CT. Can you tell us about ultrasound imaging
was I could just understand some sentences, and I'm very sorry I could not fully understand you. The first question was how we can yeah. Yeah, the fusion, and this is the complex thing, because we are only able to make a fusion if we see the applicator inside. Because the applicator in ultrasound and here the applicator in CT, this is the fixed coordinate system. But the problem is it is very hard to see the applicator in ultrasound. So what we are doing here is that we are using a tracking device, applicator tracking, with optical and maybe in future with electromagnetic tracking, because when we know the applicator and the target around the applicator, then we can also make the fusion here. So I agree. This is quite, and we need some technology for it. Otherwise, if you do it manually, you have to be very experienced that you see where is the applicator in the ultrasound. And the second question, can you repeat it? The second question was about optical.
The question is about ultrasound interest to show the dose target to higher dose to the target and lower dose. Next slide, please. Thank you. But yes, and so you can see the very high dose target and lower to the normal tissue. You have already presentation that you reduce the dose of the home units radiation to use the IMRT and out of brachytherapy that improve the dose to organize other things in this process.
And I can tell only 5 grams. At least below. So, and most cases had many. These were cannot reach the constraint because the implant is not perfect or the tumor is too large and cannot be treated well. But we should try to get it constrained as much as possible. But if you can't get it, then you are not a bad clinic. This is normal. Everyone has to struggle with this problem.
So you learned, I thought in the last slide that the development position become more concerned. So I saw in many cases that they try to decrease the position in between or avoid to decrease the dose to vagina. But the recommendation in breast mostly people to it to have been tracked in vagina about 30 to 40%. Is there anything? Is there
for the vagina, there is some interesting evidence coming from EMBRACE 1, and actually it shows that these 2 points on the left and right of the ring, or that they are not able to show any dose effect curve. What seems to be important is the ICU rectovaginal point on the posterior part, and also the fifth point. But the fifth point is mainly from the external peen. So we have, if the lower field border is very low, like here, then you have 45 gray also to the fifth -2. And those cases have a much higher morbidity than those where the field border is actually around here. So I think these points become important, also this point here, but the points left and right of the ring, maybe they will not be a recommendation in the future anymore. So the vagina is probably more important for external peen. So if you have no vaginal involvement, then there is no need to irradiate with external peen the entire vagina. And there were lots of centers in Europe who always included the entire vagina in their external peen field, and this is as it shows now, this is not needed, and this is also not good for those patients actually. So maybe brachytherapy has less importance, and external peen is even more important for vaginal morbidity because you can optimize more.
Thank you. So, any more questions? So, thank you very much, Dr. Krisits, and we hope that next meeting will be here in Bangkok. Thank you.
Yes, thank you very much.